Relaxed.
Yeah, yeah. Okay, cool. I think it's going. Yeah, it's
It's
going.
going. Okay. Hello. Hello
Hi.
out there. Welcome to episode. What number is this? Kylie, I don't even
8.
know.
8.
8. Wow, fantastic. Episode 8 of Vulva Talk. I'm Margaret Cox, a dermatologist in Salt Lake City, Utah.
And
What's
I'm Kylie
up?
Moss. Wasn't expecting that. And I am Kylie Moss, a gynecologist in Washington, D.C.
Cool,
Couple
cool.
of
This is a podcast about on which we talk about nothing but vulvas. So we have a jam-packed episode of vulvas today.
and I'm going to remember to say this is
Yes.
educational and not medical advice, which we don't always remember to say, but that is true every time.
Every
Blanket,
time, every time. It's just
blanket.
standing.
Yep.
It's a
Yep.
standing disclaimer
Yes. Yes. Episode 8 for all the episodes we
for all the
displayed.
episodes before and afterwards.
Yeah. All right. So, okay. So, two news items this week, I think. Catherine Ryan, she is a Canadian celebrity. She's in entertainment, comedy, and
Okay.
acting.
Okay.
And she talked about in an interview about her pregnancy that that her vulva was turning blue. And props to her. She used the correct terminology. But her
Yeah.
specific description was that it was turning blue like a Smurf. And
Wow.
I was, in terms of like what could be happening, and there was no comment on specifically what's going on, but I have seen blue discoloration of the vulva mainly in patients who have varicose veins that become more prominent in pregnancy.
Right.
And
Yeah.
that is because the gravid uterus, the uterus when it contains the fetus in pregnancy, presses on the big vein that drains all the blood supply from the legs, and that's the vena cava. And when that happens, the blood gets backed up in these vessels and they enlarge because they're not very strong walled, and
Right.
they can become much more visible. It's the same way that varicose veins can show up more in your legs with time and age, but this can happen kind of more dramatically in pregnancy. And so that's my suspicion about what's going on. I don't know
Yeah.
if you've had any other thoughts.
Yeah. The piece that I looked at went into a real deep dive into vulvar varicose veins.
Yeah.
Um,
They
and
can be really uncomfortable in pregnancy
yeah.
and itchy and unpleasant.
Yeah.
Yeah.
I mean, I feel like I've never personally had vulvar varicose veins, but I definitely remember when many eons ago when I was pregnant with my first child, how I did feel like I was wearing like full body compression
Just
because I
squish
feel like
everything.
I needed to keep everything in because there was so much pressure in that vulvar area.
Yeah. Yeah.
Um, but yeah,
Yeah.
that
And that,
can be pretty shocking
yeah.
to
And that
see.
same thing that causes the backflow, that causes the veins to enlarge, also causes fluid to come out of the veins, which is why you can get swollen legs
Swelling.
and that can worsen. So, yeah, pregnancy, not for the faint of heart.
No, no.
There's also
That,
Chadwick's sign, which is where the
oh yeah,
cervix
that's
on
right.
exam, like if you do a speculum exam early
Mm-hmm.
and you're in
Mm-hmm.
and you're a medical student and you're getting quizzed about it. Here's a boards question for everybody that's tuning in from the med school realm. It can be that the same reason causes a blue discoloration of the cervix on vaginal exam, but nobody
Yeah.
would ever I mean, hope not. I hope people would not confuse the cervix with the vulva, right? The vulva is
Yeah,
external,
that
the cervix
cervix
is
is hard to
internal, and
kind
the
of
opening to the uterus. So
visualize. I mean, I feel like
yeah, but
even visualizing your own vulva during pregnancy can be quite challenging.
yeah, how are you gonna get the mirror to get the right angle? It's
Yeah, it's a
very
little hard.
challenging.
So kudos
Yeah,
to her for
yeah,
bringing to light a very common change in
yeah,
pregnant people.
absolutely. And then the other thing that I saw a couple times, and this was like it was like April, May that I saw this a couple times. Like Forbes picked up um, a story about this, and it was that we have talked about labial puffing and surgery
Yes.
related
Yep.
to
Way back
labial anatomy
episode 1.
before. Yeah, from the beginning. And we've also talked about how, like, and I think 2 episodes ago, we talked about how variations in anatomy are not standard, and there's not a standardized way to know if anatomy, if the way the vulva looks is abnormal, because we just don't have that much data on it. But people are feeling like when they use GLP-1 agonist
Yeah.
medication, so medications like Ozempic, that they are having changes to the vulva because they lose fat tissue, and so the folds become less full in the
Yeah.
labia minora and majora. And so there are people who will feel like their labia minora more prominent, labia majora less prominent, and they will get like, for example, hyaluronic acid injections to make things look as they did before they went on those medications.
Yeah, so the so-called, Ozempic vulva.
Mhm. Yep, yep. I mean, I think it's the, gynecologic analogy to, or it's analogous to the Ozempic face that people
Yeah,
talk about, which is, weight
yeah,
loss that happens dramatically can cause a
yeah.
loss of elasticity of the tissue and more, prominent things like, wrinkles or other, like, fine lines, that type of thing, right?
Yeah, I hadn't really heard about this before, you mentioned it, and, that Forbes article had, kind of Ozempic everything in it, including, Ozempic face, Ozempic penis. I don't know what's that one
Oh,
about.
I had not known about that, and that's fine. I it's not my area
I didn't look
of
it up. I
expertise.
should have looked it up because I just kinda read it and was like, "Oh, I didn't know that was a thing." And then, Ozempic vulva or the saggy deflated vulva.
Aw,
Fascinating. There's a lot of, Ozempic things going on right now, and I think, related to sort of the physical changes that might happen with rapid weight loss in a short period of time. A lot of these weight loss medications can also increase your risk of, developing yeast infections, we've found, right?
yeah. I think that um I don't know, but that's balanced against the fact that when you are on these medications, your blood sugar goes down, and then long term, you may be less risk for yeast, right? Is there?
Yeah.
I don't know of a paper that is there a
Yeah, I
paper?
think it was the, I should have looked this up. The Flozin vaginitis.
Oh,
Flozin class of the SGLT2 inhibitors increase the risk of vaginitis, especially vulvovaginal candidiasis, because there's increased urine secretion. There's increased sugar in the urine. So there's
okay.
increased sugar in the urine, and
Oh,
that
I
produces
see.
a favorable environment for the candida,
So that
which
would be like
causes
Jardiance, right?
yeast
Or
infections to grow and thrive. Yeah, so
so not GLP-1
not
agonist. That
not the
would be
GLP, yeah, the other
right.
weight loss meds, the weight loss meds? Are they weight loss
I
meds?
think they're just diabetes.
Maybe they're just diabetes meds.
Yeah, yeah, yeah.
Maybe I'm
Because
confusing
that
these.
makes sense to me from a mechanistic standpoint that if you're increasing, yeah, they help with renal excretion of sugar. So that absolutely makes sense. If you're peeing out a bunch of sugar because you're eating similar things, but your blood sugar is being lowered by more excretion of sugar, getting more sugar in your urine, totally makes sense to me that you would have more yeast. But I wonder with the Ozempic and other GLP-1s if it might reduce your risk because
Mm,
it's a different mechanism. Like if you're not I think with the GLP or with the SGLT2 inhibitors, you may be, I mean, your appetite doesn't change with those, I don't think. So you're going to have similar sugar intake. You're just excreting more, which seems like a total recipe for increased yeast. But with that,
what about this idea that Ozempic causes vaginal dryness,
think that's feasible to me.
and then that can
Um,
cause, some kind of f microbiome disruption?
I mean, we see people who have, significant weight loss has effects on the brain, which in turn have effects on your reproductive system, right? Like people who have really significant weight loss, they can't. We know that people who are not having periods because they have a lot of excess fat tissue and a lot of excess estrogen can actually have normalized menses as a result of these meds. And it makes sense to me
Oh, yeah,
too that if
yeah.
you start out with normal menses because your brain is telling your ovaries to work in the correct fashion, but then you have dramatic weight loss, that you may not have as much ovarian function, right? You have to have some fat tissue in
Right.
order to make estrogen. And it makes a lot of sense to me that one of the ways that the body would respond to dramatic weight loss is to have changes in the hypothalamic pituitary axis, the way the brain sort of directs the hormones in the body, and also ovarian, estrogen production. So I think there's probably something to that.
Yeah, and I feel like that apparently is a reported side effect, um, including oral cavity dryness.
Mhm.
Um, I haven't had any patients complaining about that, I guess. I don't know. I haven't really looked
No,
at the
I
correlation
think I've had one patient on a GLP-1 that thought they were having not thought, that was reporting more vaginal dryness.
or vaginal
Um,
dryness. So did
so
you
we're I
just
mean, we're
recommend
trying
like
to
vaginal
our practice.
moisturizer, estrogen? What?
Yeah, estrogen, depending. I can't remember the precise cocktail we came up with, but I also think we're trying to do a survey study of patients who are taking GLP-1s, because like things like there's a standardized instrument called the FSFI that asks about lubrication, and we're just trying
Oh,
to ask it, certain time intervals after people start, just and at baseline to see what it looks like for them, because I really do think the lubrication domain is going to be interesting. I think
yeah,
arousal is going to be interesting. I think desire,
yeah.
orgasm, all of those things may be affected. And we know that sexual effects from medications can be a really significant reason that people discontinue them. That happens for, antidepressants. When people are profoundly depressed, they really need their meds. But if they have really low libido because their meds, they may be more likely to discontinue. So I think it's like an important aspect of the medication to understand in terms of counseling patients so they have good expectations going in, because they're life saving drugs. But we also need to understand how they affect patients holistically. Yeah.
So you guys are doing a survey, and then you're gonna
Yeah, yeah, just a
um,
survey. Yeah, yeah, yeah.
publish the results of that survey. So stay tuned.
Yeah, stay tuned. We got a couple people sort of going through the process now. Yeah. Okay. Well, you had sent an interesting article, so
Yeah,
I would
I
love.
thought we would talk a little bit about vulvar contact dermatitis, which is probably a very common thing that you see in your clinic. Definitely a very common thing that I see in my clinic. And there was a systematic review of allergic and irritant contact dermatitis involving the vulva that was published a couple of years ago now in the big dermatitis journal, contact dermatitis. Overall, not the greatest paper ever written, but I feel like it had some interesting sort of take home points. I do find that though they had two main goals with this paper. They wanted to provide a list of potential vulvar allergens and irritants that are common in the patients seen at these secondary or tertiary clinics. So a comprehensive reference list of potential vulvar allergens and irritants. And then, two, they wanted to determine whether patch testing, so that's a special test that mostly dermatologists do to identify potential allergens, whether it has diagnostic value um, when it comes to vulvar contact dermatitis. I feel like they were able to at least partially answer the first question, and they do provide a pretty lengthy list that was kind of hard for me to interpret because it was rather long. But they don't really answer the second question. And that's the question I get a lot for my patients like, "Oh, wait, I'm going for patch. Does that mean they're going to put stuff on my vulva to see if I'm reacting to it?"
Right.
And no, that is not what is involved in patch
Mm-mm.
testing. The
It's a
substances
grid
they
on your
are
back, right?
testing,
Usually.
yeah, they do it on your back. So they do it on back skin, and then the follow-up question is, well, how does that relate to how I react in the vulva if they're only looking at how I react on the back? And that's a difficult one to tease apart.
I do think it is, because I do think, I mean, now another study, we come up with like 5 different studies every time we do this podcast. But I do think there are people who like have trouble with lanolin and aquaphor, and they can use it on other parts of their body, but when they put it on their vulva, they're on fire and they can't use
Yeah.
it.
Yeah.
I think that's true. So, yeah, I
Yeah.
guess it's not necessarily generalizable. When I have a patient start a new medicine on the vulva, and I know they have like a history of hypersensitivity, I'll tell them to like test it on their arm before they put it on their genitals, and then test it on the labia majora, which is keratinized, before they put it on the mucous membrane, just to kind of work up to trying to catch any kind of hypersensitivity before they go full on in the vestibule where it's really sensitive.
Yeah. Um, and this paper primarily deals with allergic contact dermatitis. So the difference between allergic and irritant contact dermatitis is that if someone has allergic contact dermatitis, there is an immunological response that is particular to that individual that incites a rash or change in the skin. While if someone has an irritant dermatitis, anybody can have that response. It just depends on how much and for how long their skin is exposed to that particular irritant. So those
So
are the
it's like
two
the
main
human
differences here.
species got it.
Yeah.
Like, if
So,
you're
like,
a human, enough exposure will cause a problem if it's an irritant.
yeah, exactly. Especially if it's an area that, like the vulva, where there's occlusive forces, where there's thinner skin to
Meaning
begin with. So there's a
meaning
lot
not a
of
lot of
different things.
airflow, yeah,
Exactly.
and a lot of
So,
friction, yeah,
right. So not everyone is going to
rubbing.
have allergic contact dermatitis that is specific to an individual. And the irritant usually, if there's enough exposure to a corrosive enough or not maybe corrosive, but irritating enough substance, you can get a rash. So they don't really tackle too much of the irritant component here, but they do talk about the allergic ones. And the most common ones that they found were nickel. So
Yes.
nickel allergy was most common, and then cobalt allergy was the second most common. And then the question always comes, well, like, are people rubbing nickel onto their vulvar skin? How are patients being exposed to nickel in the vulva?
Right.
Is that clinically relevant? And in the case of nickel, I think the question always becomes if you're eating nickel. So nickel is found in a lot of foods out
I
there.
wanted to know this. In which
Yeah.
foods
So
is
chocolate,
nickel
for
found?
example, has a lot
Darn
of
it.
nickel. Tomatoes have a lot of nickel. Sometimes if patients have a raging nickel allergy and raging vulvar dermatitis, we'll try and do a nickel-free diet, which is very difficult
Yeah, it
because
sounds
it has a
terrible.
lot of restrictions.
It sounds like a low oxalate diet almost in terms of, like, all the good stuff has
Yeah,
nickel in
a
it.
lot of foods have nickel in them.
Huh,
Um,
had no idea.
but anyway, so the exposure through urine, through feces is the suspected
Sure.
exposure when it comes to vulvar derm in patients who
Mhm.
have a nickel allergy. Um, and then other things they found in this study were reactions to topical drugs. So a lot of topical antibiotics and topical steroids are common. And then fragrance, of course, and balsam of Peru, preservatives.
Not
Some
something I'd heard of.
patients, yeah,
Balsam of
so
Peru.
dyes as well. So especially dyes in kind of darker colored synthetic clothing.
Mhm,
Lanolin is listed on here as well.
mhm.
And then some botanical allergens, like tea tree oil. I feel like a lot of my patients are drawn to tea tree oil. In this paper, they did found that it was the most common sensitizer among essential oils. And then spices were on this list as well, including things like cayenne pepper powder, coriander powder, peppermint oil, things like that.
Yeah, and peppermint oil, you gotta watch out because 'cause they'll put it in lube sometimes.
Yeah, absolutely.
The one that I
So,
think really jumped out at me was neomycin, which is in Neosporin. And we'll have patients who have, and we used to routinely have patients who were getting vulvar biopsies put on an antibiotic ointment and just say, well, whatever
yeah,
you have at home, just put antibiotic ointment on. But it turns out a ton of people react to it. And actually, even in like burns, like really significant injuries to the skin now, I think most wound care experts are not recommending any use of antibiotic ointments just because so many people react to them. And
yeah.
your healing is worse if that happens.
Yeah, especially the over-the-counter ones like Neosporin.
Mhm.
Um, those are definitely very potent, potential
Yeah,
causes of allergic contact
81%,
dermatitis.
the individual allergen with the highest proportion of new positive reactions was neomycin sulfate. So that's the active ingredient in Neosporin. 81.5%. Just
Yeah,
don't do it. I tell people and I think you're just better off with a plain ointment anyway, right? Just generally a bland ointment like Vaseline
totally,
is probably better for wound
totally.
healing or silicone something.
The other thing I liked about this test, this paper, sorry, was that they had mentioned that they had proposed, or was it them or was it another paper? I don't know. The behind the knee test. Had you heard about that? I hadn't heard about that
No.
before. So you test out products that you're going to apply to your vulva to see if you have or potentially could have a reaction by putting it on the skin behind your knee because it better reflects the mechanical and chemical skin irritation of the vulva. So typically when I have patients try it, I'll have them do it kind of like on the
Like,
forearm or on the
yeah,
bicep here under occlusion. And here there
they're
was
saying
one
popliteal.
guy who was suggesting that the popliteal fossa was better better mimic the skin and the environment of the vulva. So
Yeah.
haven't tried that, but interesting.
No, it makes a lot of sense. More like, you know what I wonder actually, like in terms of analogies, is intertriginous regions like the axilla. Just, I mean, that seems much more mimicking of the friction that
Of the vulva.
like that people experience in the vulva. But there are lots of other things going on there in terms of like deodorants people apply and that kind of
Yeah.
thing. Anyway,
But anyway,
anyway,
I get people are always like, "Why do you hate these products, Dr. Cox?" And I'm like, because they contain things that people are likely to be allergic to, especially people who are coming in with vulvar complaints. So things like wet wipes are going to have a ton of these preservatives in them that we know are
yes,
very potent potential
baby
allergens. And yet,
wipes,
not
yes.
everyone is going to have this. In fact, the vast minority of the general population is going to have this sensitivity. But if you are part of this vulvar disease group, then I think that puts you in a separate group where the same numbers kind of don't apply. So yeah,
Yeah.
preservatives, a lot of them have fragrance in them. Um, and then things like Vagisil has benzocaine in it, which is listed on here as well. So that's the topical numbing medication that is the primary ingredient in the kind of super potent Vagisil. And that is a very common contact allergen for patients.
Yeah, we
Um,
use, do you use benzocaine, lidocaine, tetracaine ever topically for like before a biopsy?
I don't put the benzocaine in there. I just have lidocaine, tetracaine,
Oh,
and
interesting.
sometimes that burns too. So
Yeah. Oh, I
I
think it
feel
all
like
burns. I do, but I
it all
also think it
burns.
it does. I mean, I
It
tell
all
people like
burns.
it burns, but it goes away, and it
It
usually is
burns.
very
It all
helpful, I think,
burns.
in terms of reducing the pain of the injection. But I do feel like about 10% of patients with certain formulations of the benzocaine can really react to it.
Yeah.
Maybe even
And then a
5%.
lot of these over the counter and creams and things will have things that patients can be potentially sensitive to. So, we mentioned lanolin and aquaphor. And then, lots of other potential allergens here, like the propylene glycol. That's a big one, I think, sometimes.
Yes, and I do
Um,
have patients who are very cognizant about that one.
yeah,
I think people are wise to that, and they need special compounding of most things because it's in everything.
it's in everything. Yeah.
Makes things liquid when they need to be and not, congealing or solidifying, but it can be really irritating for some folks.
So that's the deal with this
Yeah.
contact dermatitis in vulvar
Which I
dermatitis.
think actually is a great segue into another potential vulvar irritant that you wanted to talk about in terms of like social media questions we see or discussions we've seen.
Oh,
Um,
yeah. I had
yeah.
this,
We always
yeah,
do pop
so
culture and a literature reference and then our social media.
yeah,
So
so
we'll
the
dive
thing
in.
that I haven't heard this for in a while. Well, actually, maybe I had a patient somewhat
Oh, I hear
recently
it weekly.
who came to me. Now I don't know, I don't. But, they were asking me about whether soaking in borax is going to help their lichen sclerosis. And it takes me back to when I first started doing this. A patient actually gave me an entire book about borax.
Ooh.
I think I had it here because I showed it to someone
I
recently
mean, we
because
have borax in my house because my kids use it to make slime,
yeah. But
which
anyway,
I
I was
hate, and it gets on my furniture.
and the paper the book itself was, it's like some self-published book, and it's all about like natural healing for lichen sclerosis with a particular emphasis on borax. And um the deal with borax is that it is a pretty irritating substance that can potentially cause further damage to already compromised skin. Um, and that's the way I view it. I do not think it has any role in the treatment of lichen sclerosis.
Mhm. And I'm a little more moderate, I would say. I don't think we have the evidence to recommend it, definitely not. Um, but I do think there are some people anecdotally who find here's my thinking about it. Yes,
Yeah.
it can be
Share
very
your
irritating, and it's also potentially toxic. Like if you absorb
yeah.
too much of this stuff, you can get into trouble in terms of your health and safety. So I do not recommend this at all. Um, it's been used forever as an industrial detergent, which is never like my go-to for something I'm gonna apply to myself. But one of the reasons it works as a detergent and as like sort of an anti-odor agent is it's antimicrobial. It does kill germs. And I do think there's probably some part of irritation and the inflammatory cascade in lichen sclerosis that can be affected by antimicrobials, right? Like, how many times have you had people come in? They clearly have other things going on that aren't necessarily bacterial infections. They were on antibiotics and they felt like they had significant improvement because antimicrobials are anti inflammatory. So I don't think that I would ever recommend borax because we don't have the data. And I appreciate what you're saying that it can be very irritating to the vulvar skin. But
Yeah. Right.
there
And
also,
so I feel like there are and then this will be like people are gonna be like, now you're a hypocrite because as a dermatologist, sometimes I do recommend bleach baths for patients
mhm,
who have
right.
atopic dermatitis.
Mhm.
So usually this is
Boric acid, which is not borax, we should say, make it very clear that they're not the
they're not
same.
the
Boric
same.
acid and borax are not the same. But boric acid is an antimicrobial that we use in tablets that we do have some data for using it
Right,
for
for
vaginitis, but
yeah.
it's not the
So
same
I
as
recommend
borax.
so I don't know, like if you're gonna do and we have data for bleach baths. Like there's tons of data.
Yeah.
I mean,
Mhm.
it's up in the air whether or not it actually is that helpful when it comes to really reducing the microbial burden of the skin in things like in patients who have atopic dermatitis who are more prone to developing skin infections. But
Yeah.
I feel like if you're gonna if you want something antimicrobial, why don't you try a bleach bath? Because at least we know that that is
What's safe?
reasonably okay for the skin.
Yeah.
And we have been doing it for a very long time, and there is larger bodies of data supporting this for that, antimicrobial element if
Mhm.
that's what we're going for.
That makes a lot of
And I
sense.
think the other thing is like for the borax, I don't know how. I mean, I guess the same question goes for bleach. Like who regulates the borax? Like what's in the borax? I don't know.
That's a great point. I mean, it's just mined. It's an industrially mined chemical. And so it's not like someone is making this in a lab under controlled circumstances. It's a rock that people dig up. And so that comes with definitely risk of contamination for sure and
Yeah.
not knowing exactly what you're getting.
So um, I when patients come to me about this, I just say there's no evidence to show that this is going to treat lichen sclerosis. That's my bottom line.
Yeah. And
And I
that's
always say,
I have enough patients come to me saying that they do it occasionally and it may help a little bit and doesn't harm them, that as long as people are doing it at pretty low concentrations and I don't see evidence on their vulvar exam that it's making them
yeah,
worse, it's
right,
like, okay, go with go with what's working for you, but I can't say that it's safe and I can't say that it's effective.
absolutely.
Yeah.
And because I feel like the skin is already so compromised in the setting of lichen sclerosis,
Mhm.
um, and more susceptible to potential irritants,
Yeah.
it just doesn't seem like a good fit here.
Fair. Fair, fair, fair. I'm just walking that line of also knowing, like, there are lots of people who have found it to be
Oh,
helpful
I
and
get
not
it. I
harmful.
get it. No, I totally,
Yeah.
I get it.
But again, I wouldn't recommend it. Don't think we have safety or efficacy data. But I also am like, oh, I do know people do. I know of this as a thing. People do. And as long as and the other thing I worry about is like if you're just going to do that and go rogue on your own, nobody's checking you for vulvar cancer or other sequelae like scar tissues, adhesions from lichen sclerosis.
Yeah,
This is not something you
totally.
self treat for those reasons.
Yeah,
So I
right.
think
I
that's
mean, yeah,
yeah.
there
Yeah,
you
yeah.
go.
There you go. There you have it.
I
I'm
love
being a
that.
softie.
I had posted something about this on Instagram and someone was like, "Why don't you do the studies showing this helps?" And I'm like,
Yeah, I mean, I don't know. It would be really tough to get an IRB approved because it's
it
not
would
like
be
you would have to go before the FDA. I think I feel opposed to animal research for various reasons, but I also
oh,
think there
interesting,
are
yeah.
ethical considerations when you're testing something on the vulva that hasn't been tested there before, and like the steps need to be very carefully considered before. That's not a trial that's that's easy to design or inexpensive to design. I mean, it would require lots of patience, lots of time, and there's no pharmaceutical company that's going to fund that, and so it would definitely need to be in a university setting. So yeah, Dr. Cox, you love
Yeah.
it so much. I don't think you're going to be spearheading that anytime soon.
No, I don't
Yeah.
think so.
All right, that's all I got.
Yeah, I think that's plenty.
Yeah, it's a meaty episode. Lots to talk about. All right, I'm Kylie Moss coming to you from Washington, D.C., board certified OBGYN. Follow me on social media, Dr. Kylie Moss, CHAILEEMOSS on Instagram and also on YouTube and Reddit.
I am Margaret Cox, dermatologist, in Salt Lake City. You can find me on Instagram, doctor.cocks. Until
Bye.
next time, bye.